Welcome to everybody. My name is Maurizio Sanguinetti. I am clinical microbiologist. I am full professor of microbiology at Catholic University in Rome. I am also the chief of the lab of the Policlinico Gemelli Hospital. And last but not least, I am the responsible of the Center of Excellence of Vieux-Merrier. This is a great honor for me, so I am very happy to be here and to share with you some information about this new technology and this new approach about the rapid antimicrobial susceptibility testing, in particular regarding VITEK REVEAL. Thank you very much for the invitation to Benjamin, to Veronique, and to all the staff of Vieux-Merrier.
Good afternoon. My name is Alessandro Russo. I am a full professor of infectious disease at Magna Grecia University of Catanzaro in the south of Italy. My research field is about multi-drug resistant pathogens from a clinical point of view and about antimicrobial therapy. Also for me, it's a great pleasure to stay here today. Thank you very much for your kind invitation. It's an honor for me to share this meeting with Maurizio and all of you. Thank you very much.
I will start with some numbers. I am sure that you know very well these numbers, but it is always important to underline that sepsis and also bacteremia is a very important disease. We are more or less 50 million of cases per year with 11 million deaths per year. So this is a very, very big problem, and the sepsis is present in 1 out of 3 in-hospital deaths. So this is a very important problem, and this problem is also related to the technologies and to the approach we use for the diagnosis of this disease. This is a fantastic paper, in my opinion, published in Spain by Spanish colleagues, in which was underlined the role, the importance of the information delay of significant bloodstream isolates related to the mortality. This is a paper produced in a single hospital comparing 2 different periods of the day. The first period in which the bloodstream results are immediately communicated to the clinician for the normal procedures, and a second period in which the lab is closed and the communication, the results is delayed. As you can see here, this is absolutely important. As you can see here, this delay in information impacts directly on mortality of the patients when we are speaking about Enterobacterales. So I think that this is a very, very important point that we have to keep in mind when we speak about rapid diagnostics. Rapid diagnostics save lives. And also the time is important. This is another paper published in Sweden, in which was evaluated the time to the therapy for ICU patients. And the paper underlined a very important point that is reported on the bottom of the slide. The 30-day mortality is increasing after 12 hours, guys, from blood culture collection. So not 1 hour, as reported by the well-known Kumar paper, but after 12 hours, of course, not in stable patients. So we can wait a little to try to put the right therapy for this type of patients. And you know that this is possible using the technology we are presenting. Of course, very rapidly, I have to remember you the 3 different moment for the evaluation of a clinical sample for microbiology in general, but in this case for bloodstream infection, the pre-analytical time, the analytical time, and the post-analytical time. Regarding the pre-analytical time, of course, is very important to send very rapidly the bottles to the lab, because of course if we lose time here is a nonsense with regards to the rapid diagnosis we can perform. So this is an important point. We have to organize very well the transport of the sample from the ward to the lab, and in an analysis we performed with Biomeurier in Policlinico Gemelli. For us, this time is more or less is a median of 3 hours. And of course, also the pre-analytical time is involved the systems used for the bloodstream infections, in particular Virtuo. Virtuo is absolutely nice machine because it's possible to upload automatically the bottles in the machine. This is not a problem now for us in Policlinico Gemelli because we are open 24/7, so there are always persons that are able to manage the bottles, but can be absolutely useful if the lab is closed in the night or during the weekend, because it's possible to put, as you can see here, you know the process, to put the bottles in the machine, and the machine is able to accept and to process the bottles automatically. And we published, as you can see here, several papers on this topic, and we obtaining very, very good results, in particular because the system is continuous monitoring the positivity of blood culture. The machine is always closed, the temperature is stable, and this is absolutely fantastic. And also Biomeurier solved by several years the problems of the neutralization media, the problems of the carbon, the old problem of the carbon, and now with the resin it's possible to eliminate antibiotics to improve the quality of the quality of the process. So now we can move to the most important part of this conversation, so the analysis. And I want to share with you our diagnostic workflow. This is the written workflow we use. All the positive blood cultures in our lab are stained, was gram stained within minutes from the positivity. Of course, we will perform this for the first BSI episode, not for the following one, of course. And this, please note that this procedure is performed always during the day, but also during the night. Then after the gram stain, if the blood culture is monomicrobial, we perform a direct Mandeltoff directly from the bottle using, this is called by us a direct procedure, and using an in-house protocol, which works very well. Then on the basis of the identification, please remember that we are working in Italy with a high level of drug resistance. If, for instance, we have a staph virus, we perform a specific molecular test to evaluate the presence of MRSA. If we have an Enterobacteriales, in particular E. coli or Klebsiella pneumoniae, we perform the Carba5 test or other tests to evaluate the presence of other resistant genes such as carbapenemase or CTXM. And if we have Enterococcus faecium, we perform the search for Van and B genes. And if the blood culture is polymicrobial, or if the identification with MALDI is not conclusive, we perform the film array BCD to try to resolve the problem. On the basis of the molecular test, but I will speak this afterwards, we perform also rapid phenotypic test. At the moment, we perform a direct VITEK 2 from the positive bottles, but we are trying to implement also VITEK REVEAL in the normal routine after the study I will present you. Of course, we perform the subculture to evaluate the definitive antimicrobial susceptibility testing. And last but not least, this is a very important point. We interact a lot with clinicians. In particular, all these results are communicated to, first of all, to ID physician, which are able then to inform the wards, and we have a direct information for ICU and for hematology. So this is a very important. The interaction with the clinician is absolutely critical, but this is the point for Alessandro. This is only the graphical representation of the process I reported before. So as you can see, we perform all these tests. Of course, this was performed always when a positive blood culture is highlighted by the instrument. We start with this process. This is quite important for the lab. Of course, we have the possibility to use MALDI. At the moment, we use Bruker, but we are implementing now the VITEK Prime to identify the microorganism, and the identification of microorganism by MALDI reduce a lot the time to identification. This is a quite old paper, but always important, in which demonstrated that implementing MALDI directly from positive blood culture, we save a lot of time. Of course, it's possible also to perform a molecular test, and this is the case in which for us to confirm identification obtained by MALDI, or to perform identification if the blood culture is polymicrobial. Only for your information, in our hospital, the polymicrobial blood culture are ranging from 11 to 12%, so not negligible. And of course, we use BioFire film array, because for us is probably the best. And as you can see, the time to results is absolutely rapid. And when compared to other machines available on the market, sometimes the other are less rapid, and sometimes are more complicated, such as EPLEX. And in particular, also the proficiency of this test was confirmed by several papers. This is one paper. This is a systematic review in which, sorry, is very small numbers, but I reported at the bottom of the slide a summary of the results. In this study was evaluated 74 studies, so a lot. More than 24,000 of samples, and molecular tests show whether 92 to 99% of sensitivity and 99 to 100% of specificity. So these tests now are absolutely have a very good proficiency and can be used without any problem in the lab. So regarding our approach, here I present you the outcome of this implementation, and the outcome is quite nice. This is the paper we published some years ago on the when we established our system, the combined system by MALDI and film array that I presented you before. By applying this algorithm, as you can see here, we reduced a lot the median time to identification. This was in this paper, but this time is also lower now, because at the time in which we published this paper, the lab was not 24/7. At the moment, this number is also lower. But in any case, there was a significant difference between the integrated model for identification and the classical model. But this is much more important, in my opinion. The implementation of this integrated diagnostic algorithm leads to a reduction in hospital stay, 5.5 days, a reduction in therapy length, 4.2 days, and a very important increase, 20% of optimal therapy at the start of antibiotic treatment. So I think that these numbers are very important if you want to convince a stakeholder to implement a rapid system. Rapid system not only save lives, and we already demonstrated this at the beginning of this conversation, but also are cost effective. If you, of course, if you consider all the hospital and not only the lab, but this is another problem. Okay, so moving to the antimicrobial resistance problem, of course, you know very well the problem, but I share with you this report. This is the report produced by the WHO, the GLASS project, this year, in a few months ago, and as you can see here, the global picture of the global picture of antimicrobial resistance is quite dramatic, probably, because 1 out of 6 lab-confirmed infections are resistant, and 1 out of 3 UTI are sustained by resistant microorganisms, and the number of VSI is 1 out of 6. So I think that these numbers are quite dramatic, and in particular underline the difficulty to put in place an empirical therapy with these numbers. So we need good results, appropriate results, to be sure about the phenotype of the microorganism. Of course, the drivers of the AMR are well known. Of course, overprescribing and prolonged empirical treatment from the human point of view, and the use of antibiotics in agriculture or in livestock. But also, of course, the global spread of resistant bacteria via travel or medical tourism. Please remember that NDM, carbapenemase, and the acronym NDM is a New Delhi carbapenemase. So this is important to keep in mind. Of course, there are also some characteristics of the microorganism, such as biofilm and other characteristics of the microorganism. But we have to underline also that the slow diagnostic, the classical diagnostic induce the not target treatment and increase the selective pressure. So this is very important because the antibiotic resistant delay targeted diagnosis and increase inappropriate empiric therapy. Of course, if I have 1 out of 6 BSI sustained by microorganism resistant, I need to use a broad spectrum antibiotics, and this is absolutely not good. And this, unfortunately, is also sustained by the problems with the diagnosis. Of course, now we are speaking from some centers very well, very good from the diagnostic point of view. But in general, we have some problems. At least I speak about Italy, with slow or inadequate diagnostics. And this, the problem is related to the prolonged empirical therapy. Only 50% of the infection treated with antibiotics receive a microbiological diagnosis. For me, this is absolutely incredible in 2025. So this is the same story that I put a diagnosis of cancer without radiology. I don't know how it's possible, but the story is the same. And of course, we need to change the approach and to use carefully and meaningfully, but to use the new diagnostics we have, as I presented before. Of course, it's possible to detect the antimicrobial resistance by molecular methods. And here for you, because the slides will be shared, so this is also a long list that I produced for you to fix the idea. So we have several pros for molecular detection. So the rapidity of the test from 0.5 to 2 hours, the possibility to identify several determinants of resistance, the molecular tests are not influenced by prior antibiotic exposure and for sure support stewardships. But we are also several limitations because, of course, the panels cover a narrow repertoire. So the genes included in the panels are not so many. The genotype is not the same for that phenotype. The genes may be silent or inactivated. Of course, no MIC are provided by a molecular test, but only the presence of a gene. And as you present afterwards, the problem of variants, for instance, for the carbapenemase, in particular for KPC, is very, very, very important. So molecular tests are good, and this is a meta-analysis we produced some years ago. The agreement between the phenotypic, between molecular tests, either versus phenotypic or genotypic system. In this case, the genotypic system means the evaluation of the genome, are quite nice, more or less near 90%, but we have some problems that I will present you before. The use of this approach impacts on the management of the patients. The answer is absolutely yes. This is a paper we published 6 years ago when we started our approach, and very simply we used this panel able to identify the most important carbapenemase and also CTXM as SBL. And as you can see here, this is an interventional study, and at the beginning of the study, the empirical antimicrobial treatment was appropriate only in 21% of the cases. Please remember that in Italy we have a lot of resistance, and this is the problem this is the cause for this very low number for empiric therapy. After notification of the results of the molecular test, more or less 20 hours from the blood culture collection, the appropriate treatment increased to 85%. So this is absolutely important, in my opinion, because using a molecular test is possible to increase the efficiency of the treatment, and also it's possible to impact on the mortality. This is a study from US. In which the authors demonstrated that the implementation of a molecular test able to identify carbapenemase impact significantly, please look here, on the mortality of the patients. With the PCR is the yellow line, and the black line is represent the patient diagnosed without PCR. Of course, the difference in mortality is absolutely significant, and of course, short also the time to results. But this is of course very easy to understand. So, to interpret the molecular AMR results in good practice, I summarize, of course, this is my personal opinion. The use of molecular antimicrobial resistant tests is very important to accelerate early decision, but we need to confirm by phenotypic antimicrobial susceptibility testing, including MIC values. We need to interpret the local epidemiology and the pretest probability to understand the positive and negative predictive value. This is very important. We have to establish reflex pathways for discordances, such as using phenotypic tests or, in some cases, but quite rare, also whole genome sequencing. We need to evaluate, to write some SOPs, because this is very, very important, and we need to communicate clearly in the report the resistant genes detecting and that the classical AST is following. Why? Because we have some problems, and this is the major problem at the moment. This is of course, always my personal opinion about the evaluation, the only use of molecular tests for the detection of antimicrobial resistance is the KPC variant. The KPC variant exemplifies how the resistant bacteria evolve under selective pressures. And this is incredible from the biological point of view. The variants of KPC are linked to a reduced susceptibility to ceftazidime-avibactam. And I remember you that ceftazidime-avibactam is the drug used exactly for Enterobacteriales producing KPC. And there is also a diagnostic escape from molecular detection and also from phenotypic, from immunochromatographic detection. So we need adaptive diagnostics and treatment strategy. This is from the biochemical point of view. There is a mutation in specific region of the gene. But the most important point from the clinical point of view, and also from the management point of view of this problem, is that at the moment, in 2023, there are more than 145 registered KPC variants. So, and this was also confirmed by this review in which all the variants are reported. Please look here at the list. Of course, it's impossible to read, but only to look at the amount of genes. And for sure, it's impossible to have a molecular test able to cover all these variants. It's absolutely impossible. We can search for some prominent variants, for instance, in Italy, KPC31, but it's impossible to cover all the genes. And also there is some problems with some phenotypic tests, because some immunochromatographic assay are not able to detect all variants, and we have also some strange situation with the susceptibility, because it seems that sometimes with KPC variants that the meropenem MIC is fall within the susceptible range, less than 2 milligrams per liter, but this is not a true susceptibility, so it's not possible to treat the infection sustained by an Enterobacteriales harboring a KPC variant with meropenem. This is important to underline. Of course, this is a report. This is a paper by the Professor Rossolini group, underlining that some rapid tests, some lateral flow assay tests are unable to identify some KPC variant. And this is a very nice paper published on antimicrobial agents and chemotherapy, stating exactly the same story. So there are some immunochromatographic tests unable to detect a KPC variant. So from this point of view, KPC variant in Italy is a problem, is a clinical problem, not only a scientific problem. So, the presence of these variants limited the use of molecular tests, and we need some phenotypic tests that have to be rapid, because we cannot wait for until we receive the results for a classical antibiogram. So we need to have a system that supports clinical decision within the golden hours. Remember that the golden hours are now more or less 12 hours. So we have several systems able to provide rapid tests. Of course, I will present you the results by VITEK REVEAL, which is the topic of this conversation, but I want to underline that probably the VITEK REVEAL is the largest panel of antibiotics evaluated. And this is very important. You know very well that the endpoint of the evaluation is the production of volatile compounds. Okay, I will present you some papers already present in the literature. This is the first one, the Tibet's paper, you know very well, published some years ago. Is a single center study, which compare the VITEK REVEAL against commercial methods, in particular sensitizer VITEK 2, with good essential agreement and categorical agreement. And we have also other two tests, other two papers. This is the first one published from the group of Cristina Costa, Professor Costa in Turin. Also in this case, the categorical agreement and the essential agreement are very good, but also in this case, the comparator is not the reference one. And finally, this is the paper from the Professor Rossolini. Also, in this case, the categorical agreement was quite good. And in this case, the TAT was 5 hours. So we can introduce this point because only 5 hours to have the results of the test. So we performed two studies using VITEK REVEAL. The first was a retrospective study in which we evaluated 50 simulated and 50 clinical gram-negative positive blood cultures. And we used, I want to underline because we spend a lot of time for this approach. We use the real gold standard. So the comparator is the ISO 27761 brought the microdilution reference standard method. We not used a commercial method as a comparator. In this first study, the essential agreement rate was 96% for simulated blood culture. We used a very challenging panel of microorganisms. And in the real life, in this study, the essential agreement was 98.8%, so absolutely high. The categorical agreement was 97.7% for simulated and 99% for real clinical sample. I present this figure to you only to underline that, okay, the times range, the time to the TAT range from 3 to 8 hours, but I want to focus your attention on the fact that the resistant organisms are released by the system very early. As you can see here, there is a significant difference between the resistant organism and the susceptible one. The mean time for resistant organism is 4 hours, and the mean time for the susceptible one is 6 hours. This is for Enterobacterales, and here in B for Pseudomonas, which is exactly the same. 4 hour 0.32 for resistant microorganism and more or less 6 hours for susceptible one. So it's possible, if we have some important sample, to provide to the clinician the presence of a resistance very rapidly. And this is the second paper we published, the second study we performed using VITEK REVEAL. This is a quite large study because we evaluated 220 clinical gram-negative positive blood cultures prospectively collected. This is not an impact study because the impact study will be presented by Professor Russo afterwards. We evaluated in this study 3 different rapid antimicrobial susceptibility testing. Of course, the VITEK REVEAL, the VITEK 2 Rust, because we as lab we perform VITEK 2 also directly from positive blood culture to save time for our clinician, and the reference method, which is the UCAS disc diffusion. Also, in this case, we use it as a comparator, the reference method, the real reference method. These are the flowchart of the study. We started from evaluating 1,800 positive blood culture and eliminating the polymicrobial, eliminating the positive blood, the blood culture positive for gram-positive microorganism. We arrive at the 220 samples we evaluated in the study. This is the pattern of resistance. As you can see, as usual from Italy, we have a lot of red. And this is the cumulative antivirograms for the microorganism evaluated in the study. We evaluated here in this figure only the species with more or 8 isolates. And as you can see, we are a lot of resistance microorganisms. So the study is quite challenging. What about the results? The results are, in my opinion, absolutely nice because the essential agreement is 97%. The categorical agreement is 98% with very few very major error or major error and also minor error. If you can also take a look to the VITEK 2, also VITEK 2 is not so bad because the essential agreement is 96%, the categorical agreement is the same that the VITEK REVEAL. But of course, the difference is made by the time. Because, as you can see here, the main turnaround time was 6.45 hours for the VITEK REVEAL, 17 hours for VITEK 2, which is quite rapid, but always 10 hours more, and also 9 hours for UCAS disk diffusion. But the UCAS disk diffusion have the big problem, at least for Italy, the big problem to be, of course, a system without MSE values. We also, because it's a disk diffusion, we can provide also susceptible, intermediate, or resistant results. And sometimes this is not so useful from the clinical point of view, at least in accounts with high level of resistance. Another nice story is that we found during the study a strain which presented a discordance between the final identification by the gold standard by evaluation and the VITEK REVEAL, because VITEK REVEAL declared that this isolate has resistance. At the contrary, either the VITEK 2 or the reference method declared that these isolates are susceptible. But looking at this diffusion, as you can see here, there is something near the disk, so it's possible a double growth, and we had the suspect that these isolates can be an heteroresistant isolate. So we perform a TAP analysis, and exactly we demonstrate that these isolates was heteroresistant. This is, of course, this is a curiosity for the paper. For the paper was very useful to be published, of course. But this could be nice also in the future. Now we are collecting some heteroresistant isolates, also in collaboration with the Center of Professor Rode in Hamburg, and we are trying to evaluate if this phenomenon is confirmed also with other isolates, because if REVEAL will be able to identify heteroresistant isolates, this would be an incredible addition to the quality, to the importance of this test. So for you, I have some facts and caveats. So how we can use the panels in real life? You have to know your local epidemiology and keep targets and database accordingly. So, for instance, we need to know if we have an evolution of beta-lactamase, so the presence of variants. If I have discordant results, I think that we need some reflex rules, repeat or target phenotypic test. In some cases, it's possible to think to whole genome sequencing, but this is possible only in some center. If I have a polymicrobial sample, Of course, I can interpret by gram stain, and I can use the BCD. What about the cost? About the cost, we have to track the KPIs. So if I reduce the length of stay, or if I reduce the cost of antibiotics, I can for sure use a reduction of the cost. And if I no mix, of course, we need to use Reveal, because Reveal provides early categorical results, and the mix can be also confirmed by the final AST. So, in conclusion, the rapid diagnostic for BSI and MRR, I think that earlier identification and susceptibility testing enables fast active therapy and improve outcomes. We can combine method, molecular for early rule-in of resistance, and rapid phenotypic test to confirm. We have to adapt an integrated algorithm with reflex pathways, and we have to implement several clinical operation values, so the reduction of broad spectrum exposure and optimization of isolation and cost saving. Reveals deliver rapid phenotypic test in hours, not in days, is at the moment to accelerate the rule-in or rule-out decision for key beta-lactam/beta-lactamase inhibitor regimens, such as ceftriaxone and avibactam. Is complementary to molecular detection of resistance, as I already presented you, and is possible to evaluate the implementation. But this is the story will be presented by Alessandro. So to conclude, if I can have a metaphor with the football, like a Champions League final, we don't wait for stoppage time you score in the first 6 hours. So the diagnostic win the match. We have a fast ID plus rapid AST. So I have a precision pass by using a molecular test, and target therapy using AST. And this can be the same story than the goal light technology. The molecular test perform the pass, Reveal is the shot, and the goal is the confirmation of the link, all within 12 hours. And thank you so much for your attention.
Thank you very much. Thank you to Maurizio for the fantastic presentation. We have a lot of things to discuss together from a clinical point of view, a therapeutic point of view. I want to do some preliminary consideration. So we have important data that confirm that a broad antibiotic therapy, antimicrobial therapy, but especially an inadequate empiric antibiotic therapy, is associated with an important mortality. We have many data about this point of view. We have some recent data. For example, this is data from a large cohort of patients published on JAMA that showed as inappropriate therapy, inadequate therapy, empiric therapy was significantly associated with higher mortality. So there is another point of view that I want to underline, that the overtreatment also was associated with an increased mortality, also in patients, in septic patients who received adequate therapy. So it's very important to understand that we have a problem about an inappropriate therapy, but we have also the problem about a broad antimicrobial therapy that is also associated with unfavorable outcome, with clinical failure, with the risk to select MDR pathogens. So we have to underline these things. We have data that show as appropriate therapy has an important impact on mortality, has an important impact on length of hospital stay. So it's very important in terms of cost for our hospital, for our health system. and on treatment failure, obviously. So we have some important consideration about the rapid diagnostic test that can help us to identify the etiology of infection and to ensure an appropriate initial antimicrobial therapy. There is another important thing that I want to show you, that the hours, so the delayed time to effective therapy is related to higher mortality. We have many data about the role of delayed time to effective therapy. It is important to underline that time is crucial for the treatment of patients, of our patients. The time is crucial to the treatment of critical ill patients, for example, intensive care unit. So we need to work on this point. We have some guidelines. For example, these are guidelines from Italian committee, Italian society, that showed us in critical ill patients the use of rapid tests can help to improve the time to appropriate therapy. It is important that it's possible that this is associated to a favorable outcome in these patients. So we know that rapid molecular identification of bacteria from blood culture is very important, and we need to work together to antimicrobial stewardship program to improve all these aspects. We have, so we know that rapid diagnostic tests impact the management of these patients. We have also consensus by the colleagues from that work in intensive care unit about the role of rapid tests in the management of these critical ill patients, in the management of this difficult to treat infection. So we have important consideration from this consensus. For example, this is a consensus from Italian society that show us the implementation of rapid tests is very important to reach an adequate treatment in critical ill patients. So we have to underline that we speak a lot about antimicrobial stewardship, but we know that the diagnostic stewardship is important as antimicrobial stewardship, because we need to improve all our diagnostic tests, to improve patients' care and outcome, to optimize antimicrobial use, to optimize the cost in our healthcare system. So it's very important to underline this aspect. We have to promote appropriate test selection, ensure time-specific collection, and interpretation and utilization of results. Maurizio showed all these important aspects. I am a clinician. I have to decide if my patients with a suspected infection, we have to decide, we have to reach bedside decision about timing of prescription. We have to decide if these patients need antimicrobial therapy. We have to understand the spectrum of etiology of causative pathogens. We have to recognize and measure the risk factor for MDR pathogens. We have to decide if we need a monotherapy or a combination therapy. And there are other important considerations about PK/PD of antimicrobials. We think about critical ill patients, we think about septic patients, the use of CRT, the use of ECMO, or other important tools that we use for the treatment of these patients. So we have some important bias about diagnostic overinterpretation. So we need to have tests that can give us important information to decide the appropriate antimicrobial therapy in few hours. There is another important point of view, in my opinion. So we, considering the role of fast microbiology today, we can wait and we can see the microbiological report before to begin an antimicrobial therapy. Out of some important emergency infection, like for example septic shock or meningitis, we can maybe wait a microbiological report to decide the right antimicrobial therapy for our patients. And we have also, however, it is important to underline that we have the Fab4, in my opinion, that are Escherichia coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter baumannii. Why these pathogens? We know that these pathogens can show different mechanism of carbapenemesis. So we have to it's very important to understand, to know the local epidemiology, and we have to work on all the treatment strategy to treat these pathogens. These are slides in which are reported the most important antibiotic that we use in our clinical practice. As you know, there is a different spectrum of activity against class A, B, C, or D about Enterobacteriaceae ambulatory calcification. There are important differences about the role of these antibiotics for the treatment, for example, of Pseudomonas aeruginosa or Acinetobacter baumannii. There is another important point that I want to show you, that we need the carbapenem sparing. Why we need the carbapenem sparing? Because the carbapenem use is one of the most important factor associated with the development of carbapenemesis in gram-negative. Why should we spare the carbapenems? Because the increased use of carbapenems driven by the spread of SPL Enterobacteriales has contributed to the emergence of this carbapenem-resistant strain. So it's very important the carbapenem sparing for this point, from this point of view, because carbapenem impact also about the role that we have in our clinical practice about adverse effect and on patients' outcome. We have data that suggest us that the new antimicrobials are very safe for the use also in critical ill patients. And we have many studies that show that other drugs are effective, like carbapenem, for the treatment of difficult to treat infection in critical ill patients. So we can consider for the new beta-lactam with beta-lactam inhibitors combination for empirical use, for a carbapenem saving strategies, and also for a combination therapy. This is my point of view that summarize that we need not to have information about the resistance to carbapenem, but today we need to have information about the presence of KPC or OXA48 or metallobeta-lactamases. So it's very important the genotype of these pathogens to understand and to decide the the appropriate treatment in few hours for our patients. So we have a large armamentarium of antibiotics. Then we have to use these antibiotics in a right way. Combination therapy, we can speak 3-4 hours if you want about combination therapy, about the role of monotherapy against the combination therapy. We have some data that show overall that monotherapy in many contexts is not different from combination therapy, also in critical ill patients. But why combination therapy? maybe because the greater mortality associated with delays in appropriate effective therapy and a broad spectrum therapy is more prudent in critical ill patients. Also, that empirical combination can cover many pathogens, can cover many mechanisms, for example, in gram-negative pathogens. And but the most important point that I want to underline that we can start with a combination therapy, but we need to promptly de-escalate to a target therapy on the basis of microbiological reports. So it's very important to understand this. So we maybe changed the paradigm and the approach in our patients. We now are in the era of empirical driven therapy. We need to know about MDR colonization, for example, knowledge of MDM enterobacterialis or MDR non-fermenters bacterial colonization status. We need to have information about the clinical status of our patients. Septic shock is very important compared to non-septic patients, and we need for an urgent appropriate active therapy. We have to understand the site of infection, HIP, ventilator-associated pneumonia, broad-stream infection, because we know that source control of infection is very important in our patients. And we have the rapid microbiology. We have multiplex PCR, we have rapid AST. So now we are in the era that we can wait and we can understand all these aspects of our patient to decide the more appropriate therapy in critical ill patients. There is a question for you. Which is the more dangerous? The KPC producing Klebsiella pneumoniae or multi-susceptible Klebsiella pneumoniae? So it's very important to understand this because we have many data. For example, this is a large cohort, Italian cohort that was coordinating by PISA that showed like MDR pathogens, bloodstream infection caused but carbapenem resistant, gram-negative pathogens was associated with an important rate of mortality, with excess of mortality is very important in this study. And we know that time for blood culture to appropriate therapy is related to an increased 30-day mortality. So we can say that multisusceptible pathogens are important, but multidrug resistant is not equal to higher virulence because we are more likely to provide inappropriate therapy during the first 24 hours after symptoms onset after the suspected infection. So this is the point that we have to underline together because we have a critical balance. We know that we have the importance of an appropriate empiric therapy because mortality increase when initial therapy is inappropriate, but we have the effect of a broad spectrum therapy on resistance. Resistance increase when broad spectrum agents are needed. Resistance has a negative impact on outcomes. So we have a collateral damage that we have to understand. This is a Klebsiella pneumonia 10 years ago. We know that 10 years ago, this is a mechanism related to KPC. So we know that KPC is the most important carbapenemesis with, for example, rate of resistance to colistin about 50% of cases, but this is the paradigm of carbapenemesis. 10 years ago, we had this Klebsiella pneumonia. And now, for example, this is a clinical case of 68-year-old man underwent surgery for kidney neoplasm that developed a bloodstream infection due to KPC-producing Klebsiella pneumonia that was detected at KPC from our microbiological tests. Can you predict susceptibility to meropenem, ceftazidime-avibactam, meropenem-vaborbactam, imipenem-relebactam? This is a KPC. So we can consider that ceftazidime-avibactam, meropenem-vaborbactam, and imipenem-relebactam are the good choice for the treatment of these patients. But if we look inside the genotype and we look inside the MIC about this Klebsiella pneumonia, we found that it was resistant to ceftazidime-avibactam with a susceptibility to meropenem. What is this? This is the first isolate. This is the recurrent isolate. This is a KPC31. This is one of the variant of KPC that now we have in our country, we have in our hospital, we can find in our clinical practice. So it's very important to know this. So we know that, for example, KPC variant are related to resistance, emergent resistance to ceftazidime-avibactam. We have the possibility to use meropenem-vaborbactam, imipenem-relebactam. The lesson is we need genotype and phenotype are important. Another clinical case. This is a broad stream infection from the urinary tract in patients with multiple kidney abscess. So you can see that we have a carbapenem-resistant Klebsiella pneumoniae with resistance to piperacillin tazobactam, ceftazidime-avibactam, ceftolozano-tazobactam. We tested also meropenem-vaborbactam. This is what type of Klebsiella pneumoniae is an ADM, NDM Klebsiella pneumoniae? No. So we know, for example, that cefiderocol against NDM-producing Enterobacterales, we can speak a lot of time with Maurizio about the testing of cefiderocol, but we have the EUCAST breakpoint about, for example, the testing of cefiderocol. And we have data from our university that show that about 40% of an ADM producing Enterobacterales showed zone diameter breakpoints over 20, 21, 23. So we know that for NDM producing Klebsiella pneumoniae, we have Alstrana-avibactam, we have cefiderocol, but we need also for NDM to know about genotype and phenotype. This is another clinical case, a female, 67 years old, with a neoplasm, important neoplasm, that developed a febrile neutropenia after chemotherapy. This is the antibiogram. What genotype is OXA48 Klebsiella pneumoniae? You can see that we have a susceptibility to meropenem, but this is an OXA48. So we need to know that this is a OXA48 carbapenemesis, because we have to use other, maybe, I think that meropenem is not the good choice for our patients, but we have other drugs, for example, cefepime-tazobactam, ceftazidime-avibactam, and also cefiderocol. Acinetobacter baumannii. Acinetobacter baumannii, in this case, we don't have detection of any carbapenemesis, but we have to test cefiderocol susceptibility, obviously, because we have also emergent resistance to cefiderocol in our strain. What about this? Maybe we know that it's difficult to test cefiderocol, but we know that there is another phenomenon that we can consider for cefiderocol, maybe in Acinetobacter baumannii. It is about cefiderocol heteroresistance. Heteroresistance could represent a step toward full resistance to cefiderocol. Antibiotic combination may be necessary to improve efficacy against Acinetobacter baumannii. We have data about the impact of cephidalcol heteroresistance on mortality, and data, for example, from credible trials showed no relationship between heteroresistance and unfavorable outcome in these patients. So we have this Acinetobacter baumannii, we have Pseudomonas aeruginosa. For example, we can have Pseudomonas aeruginosa that show this profile at antibiogram with no detection of any carbapenemesis, any mechanism related to carbapenem resistance, Pseudomonas aeruginosa, but we have the GES. We have some subtype of Pseudomonas aeruginosa that show important profile of resistance to carbapenem that are not routinely detected by our system. So the current landscape is very complex. We don't have only KPC. Molecular testing alone or phenotypic antibiogram alone are not enough to select the best antibiotic treatment in carbapenem resistant gram-negative. We need for genotype, we need for phenotype as fast as possible, and knowledge of local epidemiology. So in our decision about antimicrobial therapy, we have 4 points in my personal view. We need to have information about previous medullary isolation. We have to need information about fast microbiology, for example, multiplex PCR, and I'll show you our data about the impact of rapid AST in our intensive care unit to discriminate. What?
I think it's just a mistake, Professor Russo. I will unmute.
Okay. We have to discriminate between infection and colonization. We need the clinical features. We need to some information about, for example, biofilm and microbiome. So the information that we have at clinical worsening of our patients are about immunosuppressive state, the multi-site colonization, for example, the pathogens in respiratory tract, and lung is a very complex site for the treatment of our patients. About mono or combo therapy, we need to have information about clinical condition. We need to have information about antibiogram, and we have to decide about our therapy. We know that multiplex PCR is a very important tool in our clinical practice because we can improve our empiric antibiotic treatment. So it's very important to obtain and to have in our hospital the use of multiplex PCR, especially in critical ill patients. So we have many important data that showed like multiplex PCR has an impact on the antimicrobial use, about appropriate de-escalation, discontinuation antibiotic, about appropriate escalation of antibiotic therapy, and to reduce the inappropriate de-escalation or the inappropriate escalation of therapy. Another clinical vignette. This is a female, 83 years old, that was admitted in our intensive care unit for acute cerebral ischemic attack. A rectal scrub, we identified a Klebsiella pneumonia with phenotype KPC. After 10 days from hospitalization intensive care unit, the patients showed respiratory worsening. We identified an increasing CRP, procalcitonin. What we have to do? We have a clinical worsening and we have a rectal colonization by KPC. Maybe in many hospitals, this is the first antibiogram that we have with traditional methods that show that there is a Klebsiella pneumoniae with a susceptibility to meropenem. But this is the rapid antimicrobial susceptibility testing, the REVEAL in our center, to use in our center, that showed that maybe this is a KPC variant. So in 6 hours, we obtained the rapid AST that showed that this is maybe a KPC variant that was confirmed at genotype. So this is our experience in our center that now is under review in a journal about the use of rapid AST reveal in intensive care unit patients. We have this experience about the role in a case control study of rapid AST in 133 patients, 37 patients in which was applied AST and 96 controls. And all this population was merged was controlled about age and Charlson comorbidity index. Our data showed that rapid antimicrobial AST and an early active in vitro therapy were associated with survival in this population. So it's very important to underline that septic shock is related to mortality. So we have a population of critically ill patients in which the systematic use of rapid AST was associated with survival, and an early active in vitro therapy, and early we consider in the first 24 hours, an appropriate therapy was also associated with survival in these patients. These are the Kaplan-Meier curves that showed as REVEAL was associated with survival, the red line in this population, and the use of microbiological traditional test was associated with mortality, blue line, in this population. We also can see that an early 24 active in vitro therapy was associated with survival, the red line, in this population, and an active in vitro therapy after 24 hours from the infection onset was associated, the blue line, with mortality in our population. So it's important to underline that these are data from a single center in which we extracted a retrospective analysis of this data, but this analysis showed the possible impact of a rapid AST in very difficult to treat population of patients like the critical ill patients in intensive care unit. So we need to combine the clinical features in our bedside decision with the multi-site scrapes for MDR pathogens, with the use of multiplex PCR, the fast, the rapid AST, the source control of infection, to obtain an empirical appropriate therapy in few hours, and to obtain a rapid response from our lab to escalate or de-escalate the therapy in our patients. Thank you very much for your attention.